Thank you. I would like first to thank the M-Line Symposium on Medical Robotics to welcome us and allow us to present our CoBra project. So CoBra project is for Cooperative Brachytherapy and is an European project aiming to develop a real-time MRI guided robotic solution for precise brachytherapy. We will start first with the presentation on the on the clinical perspective of the project, followed by a presentation on the different technology models. So we will first start by the presentation of Sarah Wilby from Portsmouth University Hospital.
Good afternoon. I'm just going to share my screen. Okay, good afternoon, everybody, and thank you for joining our workshop. So this is the CoBra project. My name is Sarah Wilby, and I'm presenting on behalf of the CoBra collaborators and the team at Portsmouth University Hospital Trust, where I work as a clinical scientist. So I will give you an introduction to the project, and I will offer a bit of a clinical perspective for its importance and relevance. So the CoBra project began in January 2018, and it will end next year in September. As my colleague mentioned, it's an EU-funded project across the 2Cs region, so participating bodies can come from any of the areas in green shown on the map on the screen at the moment. So the primary aim of the project is to improve the quality of both diagnosis and treatment of localized cancers, and doing that by developing a medical robot that can be used within MRI environment. So it's very much a collaborative project. It's being run by the University of Lille. There are 2 hospitals involved, ourselves at Portsmouth and also Centre Oscar Lambert. There are 2 universities. We have the Technology University of Delft, and we also have the University of Portsmouth. We have the technology company Demcon. We also have a veterinary practice, the One Health company. We have Eurosante for their specialties in technology transfer, and Sat Nord for intellectual property. So the primary focus is, in the first instance, on advancing 2 techniques, that is prostate biopsies and prostate brachytherapy, which is a type of radiotherapy. There is a view to extend this in the future to other soft tissue sites. So why are we starting with prostate cancer? Well, both of these techniques require very precise insertion into the prostate gland with needles, which can deform and swell during the process. So there's an opportunity to replace the manual needle insertion process with a robotic technique. Another reason is that we have quite a good wealth of experience really in both techniques. So biopsies and prostate brachytherapy with ultrasound guidance have been around since 1980s. And that means that we can utilize that knowledge to understand the limitations of the process, and using those limitations, design the new technology. And just to offer some statistics, in 2020, there were 1.4 million new cases of prostate cancer globally. It's the 2nd most frequent cancer in males and caused 375,000 deaths in 2020. It's the 5th leading cause of cancer mortality in males. So I'd just like to offer a bit of an overview with regards to the biopsy practice. So the aim of biopsy is to extract cores from the prostate gland and then sending those to histopathology to diagnose or not diagnose cancer. So the prostate cores are approximately 2 centimeters in length, but they're only about 1 millimeter wide. And they can be extracted traditionally using a transrectal technique. So you can see from this image here that the needle is extracting cores through the prostate via the rectum. That's been largely replaced with a transperineal technique. So here the needles are being inserted into the prostate gland through a template and through the perineum. This photograph here is a bird's eye view. You can see the rigid template here, the ultrasound probe, the biopsy needle, and the perineum of the patient just there. Biopsies is very much a rapidly developing area. They can be template guided, as I've shown here, but there's also a trend at the moment towards a freehand approach, and the reason for that is that it gives you more opportunity to angle the needle and to access more of the prostate gland. It can be performed under a general anaesthetic and perhaps more recently under local anaesthetic. Indeed, within our trust, we do all 4 of those depending on the situation. So this graph here, which is from the National Prostate Cancer Audit, published in December 2019, just shows the rapid change from the transrectal to the transperineal approach. And this is data collected between 2014 and 2017. And from the same audit, you can see the side effects here. So the primary reason for switching from the rectal to the perineal technique is twofold, really. One is to better access to the anterior portion of the prostate with the perineal technique. And secondly, to reduce sepsis within patients. And we can see from this plot that sepsis, which is in this dark blue, has reduced from the transrectal to the transperineal approach. But what you'll also notice is that there's an increase in urinary retention. And the likely reason for that is that the number of cores being taken has also increased because we have more access to the prostate gland. And there's a direct link between the number of cores taken and the likelihood of urinary retention. But in order to reduce the number of cores that we take, we need to have real confidence in the imaging. So at the moment, a lot of the imaging that we do is ultrasound based, and this is a single slice example of a prostate on an ultrasound image. You can just about see the edge of the prostate, you can see a bit of shadowing where the urinary catheter is, and you can see the bladder, but you don't really see any detail within the prostate itself. The alternative is to use magnetic resonance imaging, MRI, which is known to offer much better soft tissue contrast. And in this image here, you can clearly see the outline of the prostate, and you can see a potential lesion here. And then we have the additional benefit of multi-parametric MRI. So we can look at this region here, which is possibly suspicious, and then back that up with the diffusion weighted images, looking at this glowing spot here and this dark spot here. And that gives us much more confidence that there is something suspicious going on here and that that is an area that needs to be biopsied. So some centres, ourselves included, will do some image registration between the MRI. So you would acquire the patient's MRI in advance, contour the prostate, contour the regions of interest, the lesion, and then in theatre, acquire the 3D ultrasound volume and do an image registration with the previously acquired MRI, transfer the targets across, and then you're able to sample the lesions contoured on the MRI, but on the live ultrasound image. So moving on to a quick description about brachytherapy. So the setup is very, very similar, as you can see from this image here. It's a transperineal approach. The difference, however, is that we're not extracting cores of tissue, we're actually inserting
Sorry, Sarah, we are losing you. I apologize. It seems that we have a problem of connection with Sarah.
Why don't we go to the next speaker, Max? And
Yes, I'm really sorry. Maybe Sarah will be able to connect a bit later and finish her talk. With all my deepest apologies. So next topic will be a presentation of the novel steerable needle design for LGR brachytherapy in the framework of the CoBra project. The talk was supposed to be made by Dr. John van den Dobelstein from TU Delft in Netherlands, but he was not able to attend to the symposium. So we have a video showing his work.
Hello, my name is John van den Dobbelsteen. I'm an associate professor at the Department of Biomechanical Engineering in Delft University of Technology.
And my name is Martijn de Vries and I'm a PhD researcher.
Within our department, we mainly focus on the development of novel medical instruments for minimally invasive therapies.
And within my research, I'm focusing on the development of a novel steerable needle design to optimize LDR brachytherapy interventions. Here the conventional LDR procedure is shown. The prostate in green and important structures around it are visualized. The needle template and transrectal ultrasound probe are positioned and 15 to 25 straight needles are placed in the prostate, leaving behind permanent seeds. However, some areas of the prostate cannot be reached because they are occluded by the urethra or the pubic arch. This may cause suboptimal dose distribution. Next to this, with straight needles, trajectory control may be lacking and sensitive tissues cannot be avoided. The designed steerable needle should allow for 1. Better control of the needle track and end location during needle placement, and 2. Allow for an enlarged reach within the prostate for a more homogeneous dose distribution. In Delft, we manufactured a compliant steerable needle comprising of an outer catheter and a steerable inner needle. Here you can see the design of the inner needle. The needle rod is effectively split into 4 quarters. The steerable needle can be actively steered in all directions during an insertion to allow for better control of the needle trajectory. The outer catheter will be left behind in the body, functioning as a channel for radioactive seed placement. At the proximal end, the segments of the inner needle can be attached to 4 piezoelectric motors used for actuation, as you can see over here. Needle tip steering up to 50 millimeters can be achieved by the use of a pull-push mechanism integrated in the needle system. Linear movement of the motors on the proximal end allow for steering at the distal end of the system, as we can see in the video. Here you can see steering of the needle when puncturing a gelatin phantom as well. Together with a needle guide, the steerable needle and the actuators form the robotic brachytherapy module. This module can be integrated in the robotic guide.
The steerable needle design for CoBra Cooperative Brachytherapy concept with an aim to perform precise dose delivery and seed deposition and extraction of cancer tissues for diagnosis, compensating the target shift and inaccessible target regions. The current version is compatible with HDR brachytherapy. For LDR brachytherapy and biopsy, the outer needle coupling is under development for seed navigation or a tissue extraction. Preliminary tests performed under real-time MRI to determine the functioning of the actuators and the integrator module. These tests were performed with agar-agar phantom. We performed a needle steering and the straight insertions of the conventional commercial in vivo COP needles, and the steering was performed in an open loop. Here you see the CoBra Robot guide with integrated needle module and the experimental setup for in-bore testing of CoBra Robot guide and needle module. The modular design of robot is capable of mounting the needle module and a biopsy module for brachytherapy as well as for biopsy. The initial tests were performed using a commercial in vivo MRI 18 gauge biopsy needle to compare the visual outcomes of an actuated MR needle with the actuated steerable needle. And the phantom imaging quality was not good as reported by MR operator, and he tried to optimize some parameters, but we were not successful, for which we intend to improve in our next tests using a commercial CIRS phantom. And our project partner is also working on the optimization of the image sequences. Following the test of straight in vivo MR needle, the steerable needle tests were performed with the same phantom. Needle was steered in open loop and performed the desired functioning and the steering. As you can see from the video, the needle is able to bend and detectable under MR images. The steerable needle in the video is made up of super elastic nitinol. It is too flexible and the phantom was protected with the silicone layer as a transperineal skin. So to perform the easier puncturing, we adapted the outer cannula with the ceramic needle. As it is initial version of the needle for the concept validation. Now the Delft team has made the stiffer versions of needle for future testing, and in our coming tests we want to improve our shielding of wires and electronic components, and to replace the agar-agar phantom with the commercial CRS phantom. And then after these tests we will go for the bio-inspired prostate phantom, and our team is also working on the optimization of the image sequences to be used. Thank you.
So this will conclude this small presentation on the work of the development of the steerable needle to a more precise positioning of the radioactive seeds. Do not hesitate to ask questions. No questions so far. So maybe we can move back to Sarah's presentation so that she can finish to present the objectives of the project and what are the challenges.
Hi, Maximilian. Yes, I will reshare my screen and hopefully it will remain stable. I'll keep my video off as I think maybe that will assist.
Thank you, and sorry for the problem of connection.
No. Okay. Okay, so we went through the biopsy practice. Looks unfortunate, as though it will last. Okay, so we were discussing the brachytherapy practice and the options for permanent and temporary brachytherapy. Whichever technique we are using, we will always have a computer planning system which we will use to individually plan on a per patient basis the distribution of radioactive sources so that we are covering the whole of a prostate. The prostate can be seen here in red, but sparing the organs at risk. So you can see how the hotter spots here, these orange and yellow colours, are avoiding the urethra, which is in green at the centre, and it's curving up at the bottom where we're trying to avoid the rectum. So there is a need for precision in both biopsy and brachytherapy. In biopsy, the lesions may only be as small as 0.5 cc in a prostate volume that can be up to 120 cc. So the only way to hit that is either to take a large number of cores or reduce the number of cores, but be very confident in your imaging. In brachytherapy, we have very steep dose gradients around the source. And the effect of this is that if you move a source, say 1 millimeter from where it should be, you can get a large drop in or change in the dose distribution in neighboring anatomy. There are a number of organs at risk nearby that are going to be susceptible to this: the urethra, the bladder, the rectum, and the neurovascular bundles. Additionally, if seeds are placed outside of the prostate capsule and they're loose seeds, then there is a risk that they can migrate into the lung, for example, or into the urinary tract. And there's interest in focal therapy. So this means boosting the dose to the suspicious lesions within the prostate. And in order to do that, again, we need to have absolute confidence in where we're hitting and where we're delivering the dose. So what are the limitations of the current practice? So we've seen that there's insufficient information on ultrasound alone. We can use image registration, and indeed that is commonly done clinically. However, there is a risk of misalignment when using both ultrasound and MRI. And indeed, the organ is not rigid, it deforms, it can move. And so really we should be tracking this deformation throughout the procedure and updating that image registration routinely throughout the procedure as we're inserting the needles and as the prostate gland is moving. Another limitation is the use of straight needles and the template. Both of those items actually limit access to parts of the prostate gland. There are anatomical obstructions that can cause a problem. So the pubic arch bones, for example, can prevent access to the anterior portion of the prostate. And that's certainly not for every patient. It's very dependent on the patient's anatomy. But with the straight needles, if you do hit pubic arch, it can be very difficult to cover that anterior portion. Furthermore, with the urethra running through the center of the prostate and at a slight angle, it makes it very difficult to cover any of the prostate above the urethra in the anterior direction. And calcifications within the prostate can cause the needles to diverge from their intended path. There is also inter-operator variability in the skill of delivering the needles to the desired position for both biopsy and brachytherapy. And another limitation is the length of the procedure. During the procedure, it's possible to see edema, so swelling of the prostate, and you can also get coagulation of blood within the equipment. So anything that can be done to reduce the length of the procedure is beneficial. Furthermore, time and cost, of course, is always a concern, particularly when theatre space is required. So what are the CoBra solutions to these limitations? Well, we heard that the primary aim is the design of a robotic arm. However, whilst this is the linchpin, without the associated modules that you see on this diagram here, you wouldn't have a complete clinically usable solution. So in addition to the robotic arm, we have the seed loader to deliver the radioactive seeds into the prostate. We have the biopsy module. We have steerable needles. We have software to model the needle path and the seed planning. We have dose calculation software for MRI, which will take into account inhomogeneities within the tissue. And we also have a bio-inspired phantom, which will allow robust testing of the whole system. And it's very important, of course, to remember that all of this is MRI compatible, so it will be possible to be used under real-time MRI. So thank you very much. We've already had part of the workshop program so far, but we will be learning about the steerable needle design, the real-time calculations, the biopsy module, the integrated robotic solution itself, and the bio-inspired phantom. So thank you very much. I hope you enjoy the rest of the workshop, and apologies for the internet issues. If anybody has any questions, please feel free to ask.
Thank you, Sarah. We do have a question, in fact. So the spectator was asking how to invite men to make prostate exams sooner to prevent this procedure. Is it safe?
Could you repeat the question, please, Maximilian?
Yep. Sorry. How to invite men to make prostate exams sooner to prevent this procedure. Is it safe?
Okay. So I think we are seeing men at early stages, and one of the recent developments that we've seen is the use of MRI for diagnosis, because whilst what I showed in the presentation just showed an example of identifying a lesion on MRI, actually probably the primary benefit is to use the MRI to have very high confidence levels of identifying patients that don't need this treatment. So using the MRI to make the decision that actually at this stage the patient doesn't require any form of treatment is something that's really progressed quite a lot over the recent years. And is the treatment safe? Certainly we have a lot of experience in brachytherapy using ultrasound guidance. So that's been around since the 1980s. There's an awful lot of data, and the benefits for brachytherapy as a single therapy or indeed as a boost for external beam is very well published. Obviously, the aim of this project is just to move that forward to real-time MRI imaging, in which we'll be able to benefit from the additional image soft tissue contrast.
Thank you. We do have a question regarding the testing of the steerable needle. So if Sepaldeep can reply, have you tried in tissue like a cadaver?
We haven't performed any needle insertion of steerable needle with the the cadaver tissues. We are in the stage of phantom testing.
So what is the program, in fact, to test all the biopsy model or the steerable needle?
In next semester, we will perform some tests with the steerable needle as well as a biopsy module with the real tissues. So first, we will perform some tests on the bio-inspired prostate phantom, which we are developing. In fact, it is on second stage. And then we will go for the cadaver or tissue testing. So far, we had made a good progress. So we are optimistic about it.
Thank you.
Maybe could I just add something to that?
Yes, please.
That, there is a disadvantage of testing on cadaver type tissue because it immediately becomes a lot stiffer than the in vivo tissue. So actually a lot of the testing that we're going to be doing on phantoms and I think later on with animals may be more realistic than the testing that you can do on cadavers. Yeah.
Thank you. Do we have any other question for Sarah or for Sepaldeep? No. So we are moving to the next presentation. So the presentation will be on real-time trajectory calculation of steerable needle for optimized brachytherapy seed deposition. The presentation will be done by Professor Ashraf Labib from University of Portsmouth.
Can you hear me? Yes. And you can see my screen?
Yes.
Yes. Okay. So I'm Ashraf Labib from University of Portsmouth. And within our team at the university, we have Professor Dylan Jones, professor in mathematics, and also Dr. Sina Firouzi, who was with us, and he is a research associate who helped us in designing the program for the steerable needle optimized brachytherapy seed deposition. Within the CoBra project, there are different tasks, and as you can see, different parts. The trajectory planning, which I'm going to zoom on here, this is the bit which we are responsible for. So this will produce trajectory planning, which will go into the software interface. University of Yale, and then the robot guide. So this presentation, I will try to present with you the formulation and the data structure used for the path planning and the real-time path adaptation program, as well as the automated algorithm for the needle trajectory planning in the context of robotic brachytherapy and biopsy. In this work, it has been assumed that the seed plan has been prepared using the traditional method and fed to the trajectory planning algorithm using conventional seed planning method. It has also been assumed that the orientation of the seeds can change because, as you may know, these seeds, the size of them is almost like the size of rice, bit of rice, and we are looking at 1 millimeter sort of accuracy. So we are assuming that the orientation of the seed itself does not affect the amount of radiation. Without because we use, as part of this procedure, we measure the amount of radiation that has been affecting the prostate. So the criteria is to achieve the dose distribution as close as possible and to minimize the number of needle insertions. The reason for minimizing number of needle insertions that we don't want to, obviously for bleeding issues, but also if we move out of the body, the needle has to be cleaned and changed. This is part of the medical requirements. So we aim as much as possible to minimize the insertion to the body itself, but within the prostate, we try to minimize, obviously, reaching to the organs at risk. So the challenges is to avoid the organs at risk, as what was mentioned before, one of my colleagues, so this is the main challenge, and also the uncertainty due to organ descending, and the radiation field from the seed is dependent on the alignment. So we developed a program that the idea of it is that it feeds to the robot controller, and the idea is to also have feedback from the MRI or simulated MRI. Also, the needle design is, the algorithm is made for a needle design comparison of straight rigid cannula and a pre-bent stylus that keeps its intended curvature once deployed inside the patient body. So the algorithm assumes a circular curvature of the stylus, which was mentioned before when we presented the video from Delft. So the MRI, one of the things, as you can see here in the MRI, that, for example, the nervous vascular bundles, which are on the bottom left and bottom right, this is one of the things which we'd like to avoid. And usually the plan, the seeding plan, comes in the shape of something like this charts here, where it shows the needles where they should be placed, because it's like a grid. And in the straight needles, this is like the matrix or the grid where the needles will go through where the circles are. So the algorithm is required to minimize the patient trauma by minimizing the needle movements and the number of insertions using oblique insertions to allow for a seed placement. One of the requirements which was set to for us is that we have to work at 1 millimeter accuracy. So this has been achieved by discretizing the geometric search space and choosing needle paths that maximize the number of seeds reachable for each needle trajectory. And the results of our algorithm and test showed that within a single insertion and maximum 5 different cannula trajectory, the seeds can be placed in their planned positions for different cases that we have tested it on. And it normally, just to give you an idea about the speed, it takes between 6 to 9 seconds to make the whole plan for the trajectory. The main limitation of our approach is that it's caused by the fact that the seeds are planned according to the conventional method. So because this planning was done based on the traditional method. So this is one of the limitations, but nevertheless, still, I mean, one of the future development is that we integrate the seed planning and the path planning into one. Okay, so conceptually, the difference is that in this, if you imagine the prostate as the organ here on the left side, and the traditional one is the top one, where the needles are straight and they go through these holes. Whereas in our case, it's one insertion, but with branches that can branch. So the conventional brachytherapy uses perpendicular to the transverse plane of the patient. In the CoBra project, we use the pre-bent needles to achieve this. So we developed a contour currently from finite element analysis. And the idea of it is that we try to simulate the prostate as well as the urethra and other organs at risk, which we try to avoid as well. So the needles obviously is bent and is trying to reach the same amount of trajectories as with the straight needle, and it generates different scenarios of path, and we try to choose the ones which minimize the number of insertions. So one of the most important assumptions to be noted here is that the algorithm receives a seed plan previously prepared, and the location of each seed must agree with the seed location in the original plan. Here it shows you the branching from the insertion, whether, for example, we go for one trunk and then the branches, or two trunks, and so depending on the optimization algorithm, and the calculation on the left side to see the assumptions in terms of the bending of the curvature of the branch, and you can see the seed here on the top right, which is in the red color. So we asked a consultant in the Portsmouth Hospital about how urologist, how he perceives the importance of either minimizing the tissue damage inside the prostate versus the tissue damage outside the prostate. And based on his judgment, these were the weightings that were inserted into the algorithm. Obviously, the algorithm can change depending on that. It has this as a variable, but 30%, so it's not as important as outside the tissue, the prostate. So we can actually insert within the prostate more freely, but outside we have to be more accurate, especially with avoiding the NVBs, which is the neural vascular bundles, because this would have lots of side effects, like, for example, erectile dysfunction or incontinence and so on. So based on that, by minimizing the weighted tissue damage as our main target, but obviously we consider the other one as well, but with using these weights, which we embedded in the algorithm, the system can generate the optimum path of the needle based on that. And having obviously into consideration as well to avoid the urethra. So this is just to show you like a simulation on how we can reach the different targets. So here you can see on the left side the normal simulation of a normal needle, straight needle, whereas here you can see the same seeds, but using the needle with the steerable needle with the curvature. So this new algorithm, the act of penetrating the prostate causes movement, as was mentioned before by one of my colleagues in the previous presentation, and the deformation, after which the correction mechanism is required. So there needs to be adaptation from the MRI about the new positions, and the stylus should be pushed out when the cannula is inside the prostate to maintain the correction mechanism. And here again, you can see the straight one from another side view versus the one which enter with an angle. Okay, so as I mentioned, the system can generate the different scenarios, and based on that can optimize the best approach. And you can see here the transverse plan versus the frontal plan view of the path from the root. This was developed into a form of software, which was embedded in MATLAB, and then this is like the user interface when you can set the different parameters. So that on the right side, this will be the outcome of the program, which says the path of the needle itself. So it can look at whether single versus multiple, whether the accuracy and the efficiency as well. So the potential advantage of this is that this program or this method in CoBra project is that the nerve damage caused by the needle at the nervous vascular bundles, they tend to affect, in the literature, it says that 50% of the patients tend to suffer from side effects like erectile dysfunction, for example. So there is a potential for CoBra project to contribute towards this, specifically toward this, using this method. The second one is that for brachytherapy is one of the methods, and it has some limitations, the current method, because, for example, if the size of the prostate is more than 50 centimeters, then it's too large for to be covered by brachytherapy. So there are some type of patients, depending on the size of their prostates, who are not qualified to have this treatment. Whereas with this flexibility with the steering needle and this algorithm, hopefully we can extend the treatment of other types of patients who are normally not qualified. For example, those with larger prostates to be treated by this treatment as well. So as a conclusion, the software is currently being integrated with the rest of the modules by the University of Lille and other partners. It is envisioned that the experiment will validate the proposed approach, And we expect maybe future research can be to explore use of machine learning, deep learning, to optimize the weightings and learn from different patients' conditions of different criteria. And also, obviously, the ultimate aim is to minimize the limitation of not having to rely on the seed plan with straight needles, which is the planning is taking into consideration the limitation of straight needles. So if we manage to combine the plan and or have the plan for our type of needle in the first place, obviously this would improve tremendously the performance of the algorithm itself. Thank you. Any questions?
So do not hesitate to type your question in the Q&A channel. No questions so far. So we'll move to the next presentation. Do not hesitate to type your question if you need, and we can ask Ashraf later on. So next presentation will be on the biopsy model, localized cancer diagnosis as part of integrated CoBra robotic solution. This work was performed by the DEMCON mechatronics teams, led by Peter Weskirk, who is not available today. So the talk will be done by Professor Rojdi Merzouki, which is a project leader from the University of Lille. Rojdi, if you can.
Yes, do you hear me? Do you hear me, Maximilian?
Yes.
Thank you. Okay. I just change. Maximilian, if applicable, I want to share the I included the biopsy module with the existing presentation of integrated robot design that we can summarize in the coming. Yes, that means the two coming presentation concerns the biopsy modules and the robot guide itself.
Okay.
Okay. Thank you so much. So good morning, everyone. My name is Rojdi Merzouki. I'm professor from University of Lille. I'm chairing this collaborative project called CoBra, Cooperative Brachytherapy. This project is supported by the program Northwest Europe, 2Cs Interreg program, which is labeled with this green maps, which represent mainly four regions from the 2Cs, including the south of UK, the north of France, the west of Belgium, and the west of southwest of the Netherlands. So the aim of CoBra project concerns the challenge of cancer control plan, where our interest is to improve and introduce new technologies related to localized diagnosis and therapy of cancers in order to improve the quality of life for patients and reduce cancer mortality. The main challenge concerning the region which is supporting this project is also to reduce the gap between different regions in order to have more accessibility for treatment of localized cancer by giving facilities from technological point of view. Now, from technical point of view, the objective of CoBra project is to develop a new generation of MR robot for invasive diagnosis and treatment of cancers based on radiation therapy. The main outputs for this project concerns the development of prototype with technology readiness level at the end of the project, which is 6, that means pre-industrialization. And then we aim from this prototype to start training for specialized target from medical staff in terms of integrated planning for biopsy and brachytherapy for treatment of prostate cancers. Then our aim at the end of the project is to create a network or to go for the industrialization of the concept from technological transfer. This is what we are aiming to work by the end of this project. Concerning the partnership of CoBra project, this is divided in 4 classes. We have academic partners from three countries, University of Leiden, University of Delft, and University of Portsmouth. We have medical partners from 2 countries, Ancovet Clinical Research Hospital of Oncology, Center Oscar Lambert, and NHS Portsmouth Hospital. We have also in our partnership cluster for medical sector, which are Santé, represented by Maximilian today, and industrial partners who are Satnor, in charge of technological transfer, and Demcam, which is SME specialized in mechatronics for medical application. Also, we have the project has a set of observers from 4 countries, European countries, mainly industrials, which can provide facilities for us to develop the robot and the environment of the robot. To make a positioning of the project or the CoBra innovation, here I want to make here a brief view about what it exists nowadays about external radiation therapy versus MRI. Actually, for the radiation therapy, we have 2 classes or 2 categories. We have external one and internal one. External, here we have a set of the accelerator that can track a target and expose a set of beams with different sources. It can be electron, proton, etc. And from the recent development, this accelerator is associated to MRI images. The aim here is to improve the detection accurately of the target with different phases, and to converge to adaptive treatment, adaptive external treatment. In this slide, we can see the 2 commercialized new generation of external radiation therapy plus MR, which call it MR Linac, from Elekta and Philips, first version, and the other model, which is Vuray technology. Yeah. So based on this external radiation therapy, our project, CoBra, of developing robot for internal radiation therapy. This is what the CoBra project wants to reach. The aim here is to go locally, or to make to guide radioactive seeds through a specific robot under MR environment to make local treatment for low or high rate of dose of brachytherapy. Now coming to the technical aspect. For the technical aspect of the MR robot developed from CoBra project, we tried first to make some specification according to the state of art, of course, and the objective of the project to reach a high TRL, that the end we can make a set of clinical trial on animals, and preparing a protocol for a human trial by the end of the project. So on this slide we can see the comparison between technical aspect of existing MR robot, not specifically for brachytherapy, but in prostate intervention. It can be also biopsy. Almost this system has been prototyped to be tested for local intervention, mainly for biopsy. Here we can see that almost the kinematics of the robots has been considered parallel. To have to maintain a good stability and accuracy than parallel or hybrid one. We can see that the comparison also in terms of sensing, we can make a control with of position or velocity of the robot based on optical incremental sensor, which is more compatible with the MR environment. So if we conclude according to our technical positioning for CoBra project, like the last line, comparing to existing one, our approach is called integrated approach. That means we want to integrate from our design all the process for of intervention, even for biopsy of brachytherapy, in terms of pre-treatment, planning, dose planning, and then trajectory planning, then the robot control, then adaptive control. This is what we want to realize as a concept from this project. So the clinical workflow for MR robotized brachytherapy can be divided, as I explained it before, in 3 phases. We have a pre-treatment phases. In this pre-treatment phases, the dosimetric planning is allowed, coming from imaging here, MR imaging, and the medical staff or clinician here makes generally the counter step for the organs to be treated, and organs of risk, and the tumors. This can be done manually by using existing software. In our case, this software is provided by our partners observers, or can be done automatically by using specific algorithms of artificial intelligence, like deep learning here. Okay, from the dose calculation, the dose calculation has been done according to the image processing developed by the clinician. The dose calculation and planning allow us to identify the distribution of the dose through the images. This should be done online, and this pre-treatment phase, we want to, through this project, to reduce it significantly or to minimize the calculation significantly in order to allow the robot to plan its trajectory automatically and generate. Then we have the treatment phase. For the treatment phase here, we have to execute the planning and to check the accuracy. What we want to control here, we want to control the tip of the needle used for the extraction of tissues or for the deposit of seeds for the treatment. We make real-time plan readjustment, and we test according to the accuracy how we can make the adaptations or final test. And after the treatment, we make the post-treatment phase. Here we need to make the reporting, the maintenance and storage until the post-implant dosimetric evaluation. Yeah, so the our main interest and positioning for the brachytherapy is the concatenation between these three phases. Okay, this is the allocation of tasks from per partners for each step of the workflow for MR robotized brachytherapy. Okay, for the biopsy we have a similar plans, but we don't have those planning in this case. Is for that we can see that the same robot can be configured for the biopsy with less tasks involved like the brachytherapy. For the now let's go for the robot guide kinematics. So our approach is first to develop a modular robot guide. This why we call it the guide, because here we need to guide a needle. This needle should be for biopsy or for brachytherapy. So the robot guide, what we see here on this figure, can hold two type of modules. These modules, one used for brachytherapy and another one for one for the biopsy, another one for the brachytherapy. This robot has 5 degrees of freedom, which is a set of different joints represented by a prismatic rotative, universal, and spherical joint, like indicated in this joint and loop graph. With the workspace of the robot, according to the both tasks, even for the biopsy or the brachytherapy, is defined by the following constraints, geometrical constant in terms of positioning. Yeah, of course, as indicated before in previous presentations, the patient here is placed in lithotomy position, and we optimized during the design of the robot the placement of the motors and the sensors to be, of course, with respect to MRI isocenter. Here you can see a view of prostate position in lithotomy configuration for a patient. In terms of robot kinematics modeling, here the kinematics all combining of course, here robot structure has the 5 degrees of freedom, including motors here, and sensors. Sensors, we have 2 types of sensors. We have encoders placed on the actuators of joint, like what we see here, and we have absolute position sensors placed along the prismatic joints. The aim to, it's more accurate, and all of them are optical, compatible with 3 Tesla or high field of Tesla MRI system. What we did at first, in parallel to the design of the robot, the modeling, the kinematic modeling of the robot. Here we have a sample of the rear side 2D model of the robot. From that, we developed a simulator, allow us to generate trajectories automatically, and to include the automatic trajectory developed by University of Portsmouth, combining with this model before testing it in real environment. On this figure, we can see the 3D trajectory reconstruction from the model, or from the forward kinematic model of the robot, by using the biopsy module and the relative on the 3D positioning errors. Here we have the few errors here in millimeters, or the 0.1 millimeters, are generally coming from some uncertainties about geometric parameter, but globally the shape is correct. External tested has been done in MR environment with our existing prototype, combining 3 Tesla MRI, our robot prototype, and bio-inspired phantom, where the design will be explained in the coming presentation. So in this case, we developed 2 types of controllers. One, a lower one, is to control the velocity of each joint according to a higher controller in terms of position. That means in parallel, we control position and velocity of each joint, which are 5 here in our case, represented by this closed loop control. And we can see here a view of one joint, which is the prismatic joint guiding the needle. Here we are exactly inside the MR environment, autonomously inside the scan. We can see that the measurements, even for position and velocity, are less disturbed in such environment, and allow us to make an accurate control in closed loop. To conclude on this robot design, we can see that actually a new generation of MR robot has been developed to perform oblique insertion through at the perineal side to target prostate targets, and with the minimum invasive entry points. This is the aim of the oblique insertion from this robot. The kinematic model has been developed also to perform and to test, of course, the functionality and the compatibility of all the components related to the actuations and sensors with the needle guidance. And as the future works with such robot development, we want to work towards adaptive brachytherapy and the MR control. This is what we explain here through this scheme. That means what we see here as an adaptive brachytherapy means how we can maintain the accuracy of the tracking for the target in presence of changes on the biological target during the multiple insertions. That means if the prostate gland is inflamed following multiple insertion or is deformed, how we can perform in parallel to or that our system can be resilient with these external changes. This is what we want to develop as a future work under the MR environment. The shoes of MR environment is principally to converge to this resilience of the system in presence and changes on the target environment. That means in presence of inflammation or in presence of deformation, local deformation, and yeah, the MR controlling the MR control allow us to make an automatic detection and adaptive control of the robot to guide with high accuracy the tip of the needle. We finish our presentation by showing this video which describe our existing lab environment with our prototype. Here we can see the motion of the 5 degrees of freedom represented here. We have 2 from this side, 2 from the other side, and 1 actuator from longitudinal one. We have here needle for biopsy, and the aim here we are the target here. We emulate the target with yeah, here conventional phantom, and the aim is to track and automatically the target inside the phantom by controlling each joint separately. We can see how this yeah, the graphics before shows the tracking or the motion of the the linear axis driving the needle from the insertion and extraction inside the phantom. Here we have the same motion of insertion inside the MR using bio-inspired phantom. We can see the tip of the needle, detect the tip of the needle. Yeah. Thank you so much for your attention, and happy to, and I make myself disponible to answer to your question. Thank you.
We do have a question regarding the previous presentation made by Ashraf. Ashraf, so do you have the literature about the damage of the nerve and vessel bundle caused by needle insertion? Did I understand correctly that for each seed, a needle path is needed?
For the first one, I don't have currently the literature, but I think maybe because it was based on our discussions with the surgeon in the urologist in Portsmouth Hospital. So maybe Sarah might have, or her colleague, our colleague Dominique, who's the consultant in Portsmouth. Regarding the insertion, yes, the seed. Each seed needle path is needed. Now we look at the system works on optimizing the picture itself, the whole plan. So it's not sequential, but it's more, it's looking at all of them and trying to take into consideration the best generating scenarios to achieve the plan, and then apply the weightings to the criteria that for prioritization. So we prioritize, or we choose, select the one which has the highest, takes the highest points. So it looks at all of them simultaneously. Thank you.
So I can add more information concerning the second question. Did I understand correctly that for each seed, needle path is needed? Yes. Our idea here is to avoid using a template for guiding the needle. So we make the deposit seed by seed, and we optimize the time of deposit by making a minimum insertion through the perineal side. That means here we use the orientation or the kinematic of the robots to when we remove when we make the deposit of one seed, we can remove the seed from the prostate and we generate maybe an oblique trajectory to make the deposit of the follower seeds, etc. This is to make a minimum insertion from the skin side, yeah, and optimize the number of insertion. And the use also, of a steerable needle can help also for making or generating different trajectories for seeds with one access point. This is what I can add as a complementary question for answers for the second question.
Thank you. So we'll now moving to the next and last presentation about bio-inspired simulation coupled active prostate phantom for adaptive intervention under MRI, done by Mr. Mario San Lopez.
Thank you, Maximilian.
You're welcome.
Hello, everyone. So I'm going to share my screen. There you go. So I'm going to talk to you about this bio-inspired phantom. What I'm going to cover is the overview of the bio-inspired phantom that has been developed in the CoBra project, the context and the previous work, the motivations mostly, the specifications that are needed for this very particular project, and then I'm going to go through the concept that has been developed, including the hardware involved, the fabrication, and the modeling and the software used. And I'm going to show you some results and which are the perspectives, the works in progress, and the future works. So first of all, this is, here you get a little picture of what it looks like, the phantom. Here you can see those are bellows that have an internal cavity. So they're used for sensing. They're purely pneumatic. So that's why there are tubings that go through. There is also another cavity that we cannot see in here, but we'll see later in the drawings that follows mainly the urethra path, and that we used for simulate swelling and edema. And yeah, there is another functionality, sorry, about those bellows, and it's that they they mimic a little bit the ligaments and other tissues that are within the body attached to the prostate. So What we want to obtain here is a phantom that can mimic especially the dynamic behavior, meaning the motion during the intervention, and that can benefit from this 3D image that can applies to the medical imaging, so MRI enhancement with respect to ultrasound imaging, and the fact that the CoBra robot can also be working in an MRI environment. So we're using the SOFA framework to calculate the deformations and displacements, since it's also a soft tissue. So we need to mimic also the deformation that is provoked during these interventions. The problems, as you have been told, is that there is deformation of soft tissue, there is inflammation that occurs, and overall displacements of targets. And we need to approximate these displacements to have a precise seed placement. And so there is an advantage additional, that is this phantom can be interesting to validate the accuracy of all the techniques that have been presented before, and that it can be useful for a faster certification process, which is economically also a big advantage. So about the context, what exists nowadays, there are some static phantoms for prostate that exist that we can buy, or that are commercial, and they're mostly being developed to generate an image that mimics with high fidelity the human tissues, and some of them that are aiming to provide a good feedback, so a good feeling, a good touch, and a good shape with respect to the real body prostate. And there is also some laboratory research work that is being conducted that can mimic a little bit the dynamic behavior, and that are aimed for surgical applications, but they're mostly not made for needle insertion or biopsy, and they are expensive, complicated to manufacture, with special procedures for 3D printing and sensors embedding, and well, overall complicated to obtain. So here you get the main scheme of what exists right now. And you can notice that there is a hole in here that we want to aim with this work. So for our project, there is this particularity of the lithotomy position for the patient, and the CoBra robot, obviously. So we need a phantom that can mimic this displacement pitch and yaw, something that is not currently being taken care of, since oblique insertions are not common, are not currently used. And also we want to mimic inflammation or edema due to lesions in the prostate. So what we have developed is based in previous work for software robotics and sensor fusions and lots of other technologies. And this is what we get. We get the 4 sensing arms, which are pneumatically coupled with pressure sensors. And there is also a 5th cavity here that is placed mostly in the path of the urethra, and that is also connected to another cavity, to another pressure source mostly, and that we use to mimic this swelling. The overall is connected to just an Arduino, and it sends the information to the host computer. So here you get a little video of how this works. So in our recent projects, obviously this all goes together with the CoBra Robot because it's a tool also to assess its accuracy. You can see a needle insertion. It's a little bit shifted just to provoke the organ motion, and this is being tracked in real time with those little gray markers that you have around here, so that we can assess the actual accuracy of the model. And it also can work as more generally an input device. This goes a little bit beyond of the medical interest and the medical scope, but it means that it can be used for some other goals that are beyond the clinical ones. Here you can see in the bottom part the simulation, so that you can see the internal cavity inflating and deflating, and you can see how the prostate slightly shifts, and we can at the same time use it to still mimic the motion of the organ. So, how do we get to these results? So here you can see some pictures of how it has been done. The body or the main tissue is made with silicone rubber, and we've made the molds with a 3D printer, a regular FDM 3D printer. And to make the cavity as precise as possible, we used harder silicone inside the cavity that we take out afterwards, so that it keeps a good stability. And also with the urethra cavity in the middle, and it's been casted in 2 halves for easier mounting. On the electronics side, we used just some pressure sensors. So here you can see mainly the setup that we use on the MRI. The thing is that there are 12 meters of tubing that links the electronics to the phantom. So these 12 meters of tubing with such small cavities provoke a very high loss of pressure sensitivity. As you can see in this graph, usually we perform these tests with 12 meters of tubing, and with correct filtering, shielding, and oversampling, we can get a very high sensitivity of just 11 pascals. And here you can see the usual setup that we use for MRI testing, in which one of the sensors is to open air, just to detect any possible electromagnetic distortions. Regarding the software side, once we get here the pressure values, there is a Python script that does the signal adapting depending on the pressure loss and the kind of phantom that we're using, and that can allow also for sequence storage, save and play, and that sends the information to the SOFA framework that performs the solving of this problem with the QP quadratic programming, minimization. So the main idea behind it is to find the forces that are involved in the environment, an environment that we have decided, and in this case it's just a single point that is pressing in the prostate. That explains best the change of pressures that have been seen in the cavities around the prostate. So this generates a Jacobian matrix that can be input to the system, and for assessing to measure the evaluation, sorry, the performances of the model with the finite element modeling and the QP solver, we performed some tracking. So here you can see markers on the prostate and on the frame, and you can see that within the 6 degrees of freedom, the resolution is quite accurate. Those graphs are taken from lab tests, and since the displacement is very little, we're falling into the path of the precision of the tracking elements. So this is the same video that Professor Masuki have told you. So this is, that has shown you, sorry. This is the bio-inspired phantom that has been placed into an MRI. So even if that was not our main interest to have a good imaging quality, it turns out that the silicon is very sharp in the images. And here you can see this model has a small, a very thin shell and gel within. So you can even see the membrane that goes around it. And for future works, we want to address the multimaterial issue, meaning obviously in the prostate you get connective tissue around it, you get a membrane that is harder on the inside, and also the cancers or any other kind of tissue that can be harder or softer. So we want to include this in inside the simulation, mostly, as I've told you, with the shell and an infilm and the sensing arms that can or cannot be from different material, depending on the results regarding the motion of the organ. And we are also looking into generating these models, these 3D models, with patient-specific data, so that particularly difficult interventions, such as Professor Ashraf talked about, especially large or misplaced prostates, can need at some point this kind of phantom, just to preoperatory planning and testing. And there is also this little feature that has been implemented in SOFA. So since we can get the motions of the prostate, and we've seen that it's quite accurate, there has been some work done to reproject this motion with a static MRI image. So there was this is a static MRI image, and this is a prostate, fake prostate moving, but the result, well, sorry about that. Unfortunately, you won't be able to see it, but the simulation can move slightly this MRI, static MRI, so that it looks like we are actually performing an MRI procedure. So thank you for your attention. This was all from my side, and I want to thank all the partners that helped me prepare this presentation for you, as well as the other partners and observers from the project. And I'm happy to answer all your questions.
Thank you, Mario. So if you have questions, do not hesitate. And you can raise your hand to let you the time to type your question. No question. So we'll, I think we'll conclude the session. So I would like to thank again Online Symposium to welcome us to present our project. And I would like to thank all the participants for their patience, because we've had quite a lot of technical problems during this symposium. I hope you enjoy the technology we have developed, and do not hesitate to contact us. I just sent the information about our website and also my details. So you can send us more question or request some specific exchange regarding the project. Thank you again.